Hey, welcome to the educational channel for nurse practitioners. I'm JB Matthew, an autonomous nurse practitioner in Right Focus Healthcare LLC. Today topic is an educational review of pharyngitis in adults. So the goal of this video is to make nurse practitioners expert in how to differentiate between viral pharyngitis, bacterial pharyngitis, and different complications, and discuss about their clinical presentation and diagnostic criteria of group A strep throat, and treatment, differential diagnosis, and how to educate patients. As we all know, pharyngitis is a common diagnosis in outpatient clinics. About 12 million ambulatory cases of pharyngitis reported annually in the United States, which represents 1 to 2% of outpatient visits. Pharyngitis are mainly caused by virus, which is 70 to 90% of the cases. And group A streptococcus are the most common in bacterial cause, which is responsible for 5 to 15% of cases. So other epidemiological factors, it's seasonal disease, and it's mostly highest during winter and or early spring. Other causative factors, people when they are exposed to cold or flu, or living in crowded areas, or children in the daycare centers, and when you are exposed to smoking or exposure to secondhand smoking. Then, as clinical providers or nurse practitioners, why this diagnosis and learning about this diagnosis is important. It is reported that when 10% of adult sore throat is being due to group A streptococcus, which need treatment, over 60% receive antibiotic prescription. So what that means, there is a lot of over prescriptions. So the goal of this educational video is for making providers more awareness regarding how to differentiate between viral and bacterial pharyngitis, and when to order the prescription so we can avoid over prescriptions. Another reason is that if anybody other than physicians or nurse practitioners listening to this channel, some of the people around you will complain. They talk to their doctor for their throat problems, or even the providers, which is not your patients, but your some people around you, they have throat problems and they did not get prescriptions, so they can get educated with this video too. Next is a definition of pharyngitis. How do you define pharyngitis? It's an inflammation of the pharynx and the surrounding lymph tissue, which is tonsils. So for the nursing students, the pharynx is the one tube which connects the respiratory tract to the larynx, and also the GI tract to the esophagus. So there will be inflammation of the pharynx and also the inflammation of the tonsils. Tonsils, when you ask the patient to open the mouth, and on either side of the back of the tongue or the throat, that is the palatine tonsils, those will be inflamed. And pharyngeal tonsil is the part close to uvula, and it's a pharyngeal tonsillar part. And the lingual tonsil is the back of the tongue, which is also going to be red and inflamed. So all these areas going to be red and inflamed in viral pharyngitis, while in bacterial pharyngitis there will be tonsillar exudates, which you're going to see in the pictures in the next slides when we discuss about pharyngitis clinical manifestations. Next is the etiology of pharyngitis. In this slide, we will talk about the viral causes and the fungal causes. First one, respiratory viruses, as you see, that is example respiratory syncytial virus, and then other virus like adenovirus, coronavirus, influenza virus, parainfluenza virus. Those viral pharyngitis always accompanied by conjunctivitis, cough, and diarrhea. Specifically not the cough, because viral pharyngitis, in viral pharyngitis there will be cough, but in bacterial pharyngitis there will be no cough. And then herpes simplex virus can cause whitish yellow plaque on the anterior mouth and lips. That is another sign we can find out the herpes simplex virus caused pharyngitis. Then the Epstein-Barr virus, which can cause infectious mononucleosis, which is an important diagnosis we shouldn't miss in the outpatient. And there will be exudative tonsillitis with fever, fatigue, and lymphadenopathy. Mostly you can see the posterior cervical node, so there will be the neck will be enlarged, and palatal petechiae. And if HIV infection is causing the pharyngitis, it can there will be all symptoms of this infectious mononucleosis, but then there will be myalgia and photophobia and lymphadenopathy. And there are some non-infectious causes, which is could be due to allergic rhinitis or postnasal drip or mouth breathing, or in females thyroiditis, or it could be from trauma, from heat, alcohol, or taking oral antibiotics like tetracycline or chemotherapeutic agents. Then there is fungus like Candida albicans. It could be the pharyngitis can be caused diffuse or patchy exudate on the mucous membrane. It could be due to the history of antibiotic use or immunosuppression. Next is the etiology of pharyngitis, bacterial cause. The main one, as you see in the slide, group A streptococci, which is an anaerobic bacteria. The other name is gas pharyngitis. It is a reason of 5 to 36% of cases. Mode of transmission is respiratory secretion or having contaminated milk or food. And this prolonged carriage of this bacteria may occurs in weeks to months. The incubation period is 2 to 5 days. Other bacteria are Chlamydia pneumoniae, Mycoplasma pneumoniae, and Neisseria gonorrhea. He's usually a chronic sore throat. Then Corynebacterium diphtheria. Then Fusobacterium necrophorum is also another bacteria causes pharyngitis. It's found in adolescents and young adults. It's the latest one found. Then the last one, as you see, peritonsillar abscess, or other name is Quinsy. How you define it, it's a collection of pus in peritonsillar space due to acute tonsillitis. So it occurs after the acute tonsillitis. There may be a history of infection prior to that. You can see the picture of peritonsillar abscess or Quinsy in the next slide. The symptoms are unilateral throat pain. It's usually caused by microbes, but the main one is group A streptococci. And then the symptoms are dysphagia, dysphonia, drooling, trismus, which means difficult to open the mouth. And then the affected tonsils may displace the uvula and soft palate to the contralateral side. There will be swelling and erythema. Next is how to diagnose group A strep throat infection. Before we discuss about group A strep throat, we will talk about the viral infection and how to diagnose viral cases. So we already talked about viral pharyngitis differs from bacterial. Viral has symptoms like cough, rhinorrhea, upper respiratory tract infection, while bacterial pharyngitis doesn't have any cough. That is one of the major signs. And then if we depend upon the virus we are suspecting, if we are suspecting infectious mononucleosis, we can do a mono test. And then if we are suspecting viral infection like HIV, then measure HIV RNA level. And then if there are lesions and we are suspecting virus or Epstein-Barr virus or herpes virus, we can do viral culture of throat and mouth lesions. And then next, coming back to group A strep diagnosis, we can remember the mnemonic center. As I show it in the slide, the first letters of the center, C as in cough, but absence of cough, that is giving 1 point. So we already don't forget that anymore. There will be absolutely no cough in if it is group A strep throat. Then exudates, tonsillar exudates, as you see in the picture. This is a picture of Quinsy or peritonsillar abscess, but that is unilateral. In strep throat there will be bilateral, and you can see that in Quinsy the left part of the tonsus is pressing the uvula towards the contralateral side. And then nodes, anterior cervical nodes you can palpate, and there will be tenderness. We give 1 point. Temperature greater than 38 38 degrees Celsius 1 point, while virus there will be no temperature and patient is febrile. And then age modifiers, pay attention to it. 15 to 44 years, it's not much significant, that is right, the point is 0. And 45 years, we are not thinking even as much as 15 to 44 years as of group A strep throat. So the total test, the maximum score an adult can get is 4, and if it is scoring 4, go ahead and order empiric antibiotics. And if it is 0 to 2, no testing or antibiotics. And if it is greater than 3, rapid antigen test, which is if negative, no antibiotics. But if it is less than 20 years and negative, do a throat culture. And a positive throat culture, which is sensitive of 90 to 95%. Rapid antigen detection testing or RAT test to confirm the diagnosis of group A streptococcal infection. Regarding the close contacts, screening is only needed if they have a history of rheumatic fever or glomerulonephritis, or they are symptomatic. Next is about Quinsy, peritonsillar abscess. You can see in the picture it's unilateral and there is inflammation, unilateral tonsil enlargement, and it's pressing the uvula towards the contralateral side. And I will discuss the treatment in the next slide, but the referral to a clinician who can perform needle aspiration of abscess or culture or CAT scan or ultrasound is the best option. This treatment of pharyngitis. For viral pharyngitis, we can do symptomatic treatment, analgesics for fever and pain, like Tylenol or ibuprofen, and then advise to the patient a lot of fluids, and then take rest, and then advise to take do saltwater gargles and throat lozenges. And then we can use the same treatment as supportive treatment for streptococcal pharyngitis. But once it's diagnosed, we need to order antibiotics. So the first line treatment is penicillin V, 500 milligram TID for 10 days. And then amoxicillin once daily for 10 days, or 500 milligram BID for 10 days. And then if the patient is allergic to penicillin but not severe allergy, we can order cephalexin 500 milligram BID for 10 days. And then if there is an anaphylaxis reaction, we can do macrolides, but the experts recommend avoid macrolides in the treatment of pharyngitis. So we can order azithromycin 500 milligram daily into 5 days, the CPAC, or Biaxin 250 milligram BID for 10 days, or clindamycin 300 milligram TID for 10 days. And also intramuscular penicillin is also an option. Next is the treatment of peritonsillar abscess. We already discussed in the last slide about it, about the clinical presentation. And then we have the first line treatment is needle aspiration. If that fails, we can do incision and drainage. That should be done by expert clinicians who can do drainage on the peritonsillar abscess. And then if that fails, we can refer to ENT surgeons for tonsillectomy. The antibiotics we can order is Augmentin 875 125 BID, or 500 125 TID for 7 to 10 days, or if the patient is allergic to penicillin, even though macrolides are not favorable for the pharyngitis treatment, we can order clindamycin 300 to 450 milligram every 6 to 8 hours for 10 to 14 days. And we can refer the patient for hospital admission if patient cannot breathe or cannot swallow fluids, or there is uncontrolled pain, or there is some severe immunocompromise. So I did not talk about the IV antibiotics because we are talking about the outpatient pharyngitis treatment. Next is differential diagnosis for pharyngitis. In any of my videos, I haven't added so far differential diagnosis, but I think in pharyngitis, it's important not to miss these diagnoses, especially infectious mononucleosis and herpes simplex virus. Allergic rhinitis can cause pharyngitis, and cancer of the head and neck And also, if the patient is complaining of throat pain and unable to swallow, we should check it out, especially if the patient has a history of sore throat and had treatment or any history of like that. We should check for peritonsillar abscess, and we should not miss that diagnosis. Next is the complications of pharyngitis. Untreated pharyngitis can lead to very serious complications, which involve suppurative complications and non-suppurative complications. Suppurative, we know the meaning, which is pus formation, but there is another meaning to it. Suppurative is happening, complications are happening directly because of the pharyngeal infection, while non-suppurative complications happen because of the immune response happening due to the acute infection. So first is scarlet fever or scarlatina, and that is usually suppurative. So there is pus formation. You can see the picture, and the speciality of that is the rash appearance, which is usually happens within 24 to 48 hours after the infection, and it lasts 4 to 10 days. And then the face has a flushed appearance. Petechiae may be present, but the rash fades 3 to 4 days after the onset. As you can see, there is generalized rashes on the second picture, and which happens first in the abdomen, then it spread to the neck and the limbs. Next is a glomerular nephritis, and you see that it's non-suppurative. So even if we treat with the antibiotics, that would have not prevented it. Maybe the immune response because of the infection. Then cervical adenitis, it is suppurative. So we will feel a tenderness in the lymph nodes, and peritonsillar abscess we already discussed. That's also suppurative. Then acute rheumatic fever, which I did not specify much because it's a cause of death in age 5 to 20 years. So that means it's mostly in the young children, but that is very important. That is why identifying streptococcal infection in young children or young adults is very important, because we can prevent the rheumatic fever, which is a leading cause of death. Acute rheumatic fever is a major topic which itself need a full video on the topic, so I'm not discussing that in this video. Next is education to patients and follow-up. Advise them no return to school or work until at least 24 hours after beginning antimicrobial or antibiotic therapy, and tell them to report if there is severe pain or dyspnea, and advise them to increase fluid intake. Ensure the patients know that there will be an improvement within 24 to 48 hours, and if there is no improvement, follow within 3 to 4 days, and also educate them about the complications of pharyngitis and why they should complete the course of treatment, which is whichever day, how many days it's ordered. It's 10 or 14 days or 7 days. So they should complete the treatment so there is no complications. And we have reached the end of the video. So I'm concluding here, and if any nurse practitioners listening to this video have benefited from this video in clinical practice, or this would benefit you, please subscribe to the channel, and thank you for listening.